This is part B of the Alterations in Cognitive Systems, Cerebral Hemodynamics and Motor Function. We're going to be talking about the alterations in cerebral hemodynamics. First, let's talk about the overall components of the brain. We have 80% brain to 12% blood and about 8% CSF. And understanding this, we know this to be the Monro-Kelly hypothesis. If we increase one component, it's going to decrease the other component, which is estimated to be a total of 120 milliliters in volume. So keep this in mind when we talk about increased cranial pressure. Now, normal cranial pressure should be between 5 to 10 millimeters per mercury. And some texts will actually say 0 to 15 as well, but in that range. Now think about what are some of the things that could actually increase your cranial pressure. Maybe sneezing. If your patient's bearing down, this can cause short increases of intracranial pressure. When you have prolonged increases of pressure, usually about 15 millimeters of mercury or more, it's going to be defined as increased cranial pressure, or ICP. The pathophysiology of intracranial pressure involves a progression through 4 different stages. And we have the initial compensatory stage, which occurs when the body attempts to maintain a normal intracranial pressure. Though the compensatory mechanisms such as cerebral vasoconstriction, displacement of cerebral spinal fluid, and alterations in the brain tissue compliance, they all have to be working in order to help to maintain normal ICP. However, as the intracranial pressure rises, the decompensatory stage is going to follow, where compensatory mechanisms are now no longer effective and the ICP can reach levels that will now impair cerebral blood flow. Okay, so compliance is lower, so you have a higher risk of ICP. If the increased ICP remains unresolved, the brain will then enter a stage of herniation, and there's going to be displacement or herniation of brain tissue due to this increased pressure that's exerted. The stage is now a medical emergency, and it can lead to severe neurologic damage and even death. And if it's not treated, it could be irreversible. The last stage is when brain death can occur if the elevated ICP persists, and it can also result in cessation of overall brain function. This is when ICP rises to lethal levels. So let's talk specifically now that you got an overview. Let's talk specifically now about stage 1 and stage 2. Now, stage 1 is a phase of potential danger, okay? And it's from one of the complications listed previously that we talked about, right? In stage 1, intracranial hypertension, vasoconstriction, and external compression of the venous system occurs in an attempt to then decrease the ICP. It's trying to compensate. But during the first stage of increased intracranial pressure, that pressure may not change because the compensatory mechanisms are still effective. So your patient will only experience few symptoms. The small increases, though, in volume, however, can increase the pressure, and the pressure may take longer to return to baseline. It can be detected with intracranial pressure monitoring, even at stage 1. In stage 2, there is a gradual rise in intracranial pressure, and this will cause cerebral perfusion to drop. You're going to have a decrease in oxygenation that will then stimulate vasoconstriction to occur, because when your body understands that there's not enough oxygen, it's going to try to increase the cardiac output. This is done by vasoconstriction. What you'll have as a result in lowered consciousness of the patient. In stage 2, your body is not able, or your brain space is not able to compensate. There's continued expansion of the intracranial contacts, and the result is an increase in ICP that's going to exceed the brain's compensatory capacity to adjust to the pressure. You're going to have a compromise in neuronal oxygenation, and systemic arterial vasoconstriction will occur to try to alleviate the systemic blood pressure. Clinical manifestations at this stage are usually subtle and transient, but you're going to see episodes of confusion, restlessness, drowsiness, and maybe even slight pupillary changes, and also breathing changes as well. And you can see here the clinical correlates of compensated versus uncompensated phases. So remember, here we're still in the stages of compensation. Now, stage 3 is established when there's a rapid rise of ICP at a point where you have decompensation, autoregulation is lost, and you're going to have increased blood volume in the brain. You're going to have hypoxia and cytotoxic edema that occurs as well. And it's just going to make things worse because there's not enough space for all these things to happen. Remember the Monroe-Kelly theory. And this is going to cause coma to deepen. You may see patterns of apnea for 15 to 60 seconds, followed then by deep labored breathing. And this is called Cheyne-Stokes respiration. And you may recall this type of breathing from your respiratory pathophysiology. With this type of breathing, carbon dioxide is going to accumulate, which will then induce a cycle type breathing. Hypoxia and vasoconstriction is going to stretch the pressure receptors in the carotid arteries, which will then signal the medulla to induce bradycardia. With stage 3 intracranial hypertension, you're going to have ICP that approaches arterial pressure. The brain tissue is going to experience hypoxia, hypercapnia, which is too much CO2, and then your patient's condition can rapidly deteriorate at this time. Clinically, you're going to see decreased levels of arousal, central neurogenic hyperventilation, widened pulse pressure, bradycardia, and pupillary responses. They become very small and sluggish. Dramatic, sustained rises in ICP are not seen until all the compensatory mechanisms have been exhausted. Once this happens, a dramatic rise in ICP can occur, and this can be over a short period of time. Autoregulation, which is a compensatory alteration in the diameter of intracranial blood vessels, are designed to maintain a constant blood flow during changes in cerebral perfusion pressure, but at this time it's all lost with progressive increased ICP. So CO2 accumulates. This is going to cause vasodilation locally, but you're not going to have autoregulation of this vasodilation. So you're going to have perhaps hydrostatic blood pressure in the vessels to drop the blood volume to increase. The increasing pressure is then going to obstruct venous outflow. Now, the brain volume at this time is going to be further enhanced as your intracranial pressure continues to rise. These small increases in volume, though, at this time can cause very dramatic increases in your ICP, and the pressure will take way longer now to return to a baseline, as it was able to do more quickly in stage 1 and in stage 2. The brain tissue experiences severe hypoxia, hypercapnia, and even acidosis. all in which will cause cerebral vascular vasodilation. Okay, your patient is decompensating very quickly. And then we progress to stage 4, which is where cerebral perfusion pressure is going to fall below 30 millimeters per mercury. At this point, widespread necrosis is going to begin, and the compression of the brain stem, the respiratory center, will lead to respiratory arrest and death. In stage 4 of intracranial hypertension, the brain tissue is going to shift, or what we call herniate, and it's herniating from the compartment of greater pressure to a compartment of lesser pressure. This ICP in one compartment of the cranial vault is not going to be evenly distributed throughout the other vault compartments. So with this shift in brain tissue, the herniated brain tissue's blood volume becomes compromised, and this is going to lead to even further ischemia and deficits of perfusion. You're going to have hypoxia in the herniating tissues. The volume of content within the lower pressure compartment will continue to increase and exert pressure on the brain tissue. Small hemorrhages often develop in the involved brain tissue at this time. Obstructive hydrocephalus may develop during stage 4. This herniation process is going to be markedly and rapidly increasing your patient's intracranial pressure. Which of the following mechanisms play a significant role in the pathophysiology of increased intracranial pressure in a patient with traumatic brain injury? The answer here is impaired reabsorption of cerebral spinal fluid, or CSF. With traumatic brain injury, or TBI, it often leads to increased ICP due to various mechanisms. One significant mechanism, however, is contributing to increased ICP is the impairment of the reabsorption of cerebral spinal fluid. So in normal physiologic states, your CSF is continuously produced by the choroid plexus, and it circulates through the brain and the spinal cord. And it's providing a cushion, and it helps to maintain a very stable intracranial environment. But when you have a traumatic brain injury, the normal flow and absorption of CSF is disrupted. The damage caused to the structures in the circulation will hinder the proper reabsorption of CSF. So as a result, that CSF will accumulate in the ventricles and the subarachnoid spaces, which will lead to this increase in intracranial volume. Subsequently, you're going to have an elevation of ICP. The answer here is B. Let's look at the alterations in cerebral hemodynamics in terms of cerebral edema. Cerebral edema is an increase in the fluid content of the brain tissue, the net accumulation of water within the brain. The result is increased extracellular or intracellular tissue volume in the brain, and it occurs after the brain has been insulted from trauma, infection, toxicity, hemorrhage, tumor, ischemia, infarction, or even hypoxia. The harmful effects of cerebral edema, this is caused by the distortion of your blood vessels, the displacement of tissue in the brain, increased ICP, and eventual herniation of brain tissue from one brain compartment to the next, right? So what we just described here is the continuity of the stages 1 through 4. Increased permeability of capillary endothelium of the brain after the injury to the vascular structure. This is going to cause something called vasogenic edema. Cytotoxic cerebral edema, this is caused by a failure of active transport systems, whereas interstitial cerebral edema is most often seen in patients with non-communicating hydrocephalus. That means that the fluid isn't moving from one space to the next. It's not connected. Ischemia specifically, though, is more commonly the cause of cytotoxic cerebral type edemas, where vasogenic edema occurs due to the breakdown of the tight endothelial junctions that make up the blood-brain barrier. Well, this is going to allow the intravascular proteins and fluids to penetrate into the parenchymal extracellular space, and the injury will cause a failure in the blood-brain barrier, which then will result in leaking. Now, cytotoxic is the most common that's seen in cerebral ischemia, and this is where extracellular water passes through the cells, resulting in cellular swelling. This is why we got the term cytotoxic. Post-injury ischemia, intercellular pump failure, will cause swelling of the individual cells of the brain that's seen, and this is the main distinguishing characteristic of a cytotoxic type edema, different than vasogenic edema, where there's an influx of fluid in the interstitial space rather than the cells themselves. Okay, so this will help you to determine if it's cytotoxic or vasogenic, because cytotoxic is the actual cell. Also worth noting is cytotoxic type brain edemas or cerebral edemas occur in the gray and white matter, where vasogenic only occur in the white matter area of the brain. The term hydrocephalus, this refers to various types of conditions that are characterized by the excess of fluid within the cerebral ventricles. It can also be in the subarachnoid space or both. With hydrocephalus, you're going to have interference with CSF flow that's caused by increased fluid production, or obstruction within the ventricular system, or defective reabsorption of that fluid. A tumor of the choroid plexus, which helps to generate CSF, can also cause overproduction of CSF. Hydrocephalus can be something that develops in infancy all the way through adulthood. When we say that there is communicating versus a non-communicating, this means that the areas, the ventricles, have a connection to one another. With non-communicating, this is intraventricular or internal. The obstruction within the ventricular system occurs more often in children. Non-communicating hydrocephalus will more often be seen in our pediatric population. There's impairment of the absorption of CSF from the subarachnoid space, and usually it's an obstructive process that disrupts the flow of CSF through this subarachnoid space. With communicating type hydrocephalus, this is more common in adults. It's non-obstructive and it's in the extraventricular area. And this is from impairment of the reabsorption of CSF in the absence of obstruction between the ventricles and the subarachnoid space. When we have acute hydrocephalus, this is happening several hours when a person has sustained some type of traumatic brain injury, and you're also going to see an increase in intracranial pressure. We also have hydrocephalus with normal intracranial pressure, and this can be idiopathic from meningitis, trauma, radiation even, or dementia. Gait disturbances, urinary incontinence can be seen with this normal pressure type hydrocephalus. The diagnosis of hydrocephalus is with the basis of clinical history, physical exam. You'll need a CT and MRI. Also, most cases of hydrocephalus will develop gradually and insidiously over time, but there are times where we have acute hydrocephalus as well, and you're going to have more rapid developing situations. And it can develop into coma quite quickly in this acute stage. Remember, more associated with sustained head injuries. We're now going to talk about alterations in neuromotor function. You can use this table to look at the differences between hypotonia, flaccidity, hypertonia, spasticity, peritonia, dystonia, rigidity, cogwheel type movements, um, myotonia, alpha gamma type movements. We will highlight the most common ones, first starting with hypotonia. And this is when we have a decreased muscle tone, so hypotone. Uh, Decreased muscle tone, you'll have passive movement of the muscles that occur with little or even no resistance at all. When someone is in a state of hypertonia, this is a symptom of cerebellar and pure pyramidal tract damage. It's thought to be caused by decreased muscle spindle activity that's secondary to decreased excitability of the neurons. It contributes to a patient's ataxia. Also, intention tremors are very common with hypotonia as well. And in cerebellar damage that manifests with minimal weakness, and also can be slightly exaggerated reflexes that can occur with hypotonia. Often, hypotonia can be described as flaccidity as well. And this is a state in which the muscles may move rapidly without any resistance. And it occurs when nerve impulses necessary for muscle tone are lost. And this can happen with a spinal cord injury or even a cerebral vascular accident or stroke. Our patients with hypotonia, they report being tired very easily, or they report being very weak. They have difficulty sitting, or sitting without some type of support or armrest. They have difficulty with walking up and down stairs, can't stand on their toes. Because of the weakness, they are more prone to accidents during motion. And self-care activities are very difficult as well, and they're more prone to accidents during these self-care activities. The joints may appear very loose, and muscle mass atrophy can occur as well. With patients with hypertonia, this is increased muscle tone, and passive movement of muscle occurs with much resistance to stretch, and it's caused by upper motor neuron damage. There's 4 types of hypertonia that we can discuss. The first one is spasticity, peritonia, dystonia, and rigidity. And more often you're going to hear about spasticity and rigidity. Now, spasticity results from the hyperexcitability of the stretch reflexes, and it's associated with damage to the motor, premotor, and supplementary motor areas, as well as the lateral corticospinal tract damage. Spasticity is accompanied by increased deep tenon reflexes. So if you checked your patient's DTR, they would be hyperreflexive. And you also have some clonus as well. With rigidity, this produces a tonic reflex activity that's mediated by the gamma motor neurons that can be continuous or intermittent. And this is different from spasticity because with spasticity, it was the overactivity of the alpha motor neurons. Okay, so now we're talking about the gamma motor neurons with rigidity. The involved muscles are firm, they're tense, and there's increase in muscle movement even with a passive range of motion. There are 4 types of rigidity that are further defined here. You can see plastic or lead pipe, cogwheel, gamma, and alpha. Now, cogwheel, I'm just going to point this out because we see this type of movement with our Parkinson's patients, and this is associated with basal ganglion damage. The term hyperkinesia, this is where you'll see excessive purposeless movement. With patients that have Huntington's disease, they will have hallmark chorea, which is a type of hyperkinesia. Tardive dyskinesia is an involuntary movement of the face, the trunk, the extremities, where paroxysmal dyskinesias are abnormal involuntary spasms of movement. That term hyperkinesia is an umbrella term that will include both tardive and paroxysmal dyskinesias. You can see also with tardive dyskinesias that the most common symptom is rapid, repetitive, stereotypic type movements like continuing to chew, lip smacking, and protrusions of the tongue outward, and even facial grimacing. Occasionally, you'll see tardive dyskinesia with our Parkinson's type patients. If you want to see the hallmark type chorea, you can push play on this YouTube video that's showing a patient with Huntington's disease. Huntington's disease is a nerve cell type damage that will affect the whole brain, and certain areas are more vulnerable than other areas of the brain. And we'll be talking more about Huntington's specifically in a moment. You can see here there are different types of hyperkinesia syndromes. Again, remember this is an umbrella term that chorea will follow underneath, and this is the non-repetitive muscular contraction of the face. You also see random patterns of irregular, involuntary, rapid contractions of groups of different muscles, and it disappears with sleep. It decreases when your patient's resting, and it increases when there's any type of emotional stress or when they attempt voluntary movement. It's associated with excess concentration of or a supersensitivity to dopamine within the basal ganglia. So I'm not going to read through all of these different types of hyperkinesia syndromes, but I do want you to go through and try to pick out some ones that are associated to the different changes in dopamine. This is one way to look at this chart, and also where it's affecting the brain, specifically if it's affecting the basal ganglia. This is something to also look at as well. The term hypokinesia is the decreased loss of voluntary movement, and it's despite preserved consciousness and normal peripheral nerve and muscle function. It is also an umbrella term, and with it we have akinesia, bradykinesia, and the loss of associated movement. So akinesia is a decrease in voluntary and associated movement, the dysfunction of the extrapyramidal system, and it's caused by either a deficiency of dopamine or a defect of the postsynaptic dopamine receptor itself. And this occurs in Parkinsonism. Bradykinesia is when we have very, very slow, so that prefix Brady, voluntary movement. All the voluntary movements of your patient are going to be slow. They're going to look very labored and deliberate with difficulty. They're going to not be able to initiate their movements very quickly. They continue to move, but it's very difficult to move smoothly, and it's very hard to perform synchronous activities or consecutive tasks. Normally, habitually associated movements that provide skill, grace, and balance to voluntary movements will become lost as well. There will be a reduction in arm and shoulder movements, hip swinging, rotary motion of the cervical spine. And if you can imagine those movements that are associated to walking and getting from one place to another will be lost or altered. In Huntington's disease specifically, so we also know this as chorea, and it's a relatively rare hereditary degenerative hyperkinetic movement disorder, and it involves the basal ganglia and the cerebral cortex. The onset of Huntington's is actually very young, 25 to 45 years of age, and it's passed familially to the person's child or children. And the prevalence is approximately 5 to 10 per 100,000 people. It occurs in all different races, and the rates vary in different regions across the world, however. Now, Huntington's disease by pathophysiology is inherited from one or both parents who have an autosomal dominant trait. The genetic defect of HD or Huntington's disease is on the short arm of the chromosome 4. And you're also going to see that there is an age of symptom onset that's related to the length of the repeat sequence and the mechanism of toxicity that occurs in the CAG, which is the cytosine adenine guanine portion of your gene. And with repeat lengths greater than 60, this is going to cause juvenile forms of the disease. Now, fathers, but not the mothers, with high normal alleles don't develop Huntington's disease, but they are at risk for transmitting potentially penetrant type of the Huntington's disease alleles to their offsprings. So they are still at risk for moving it forward to the next generation. The principal pathologic feature of HD is the severe degeneration of the striatum. And this degeneration in the basal ganglia is going to leave enlarged lateral ventricles. You're going to see widespread degeneration in the late stages of the disease, however. There's going to be lysosomal autophagy that's disrupted. It's going to result in the accumulation of these misfolded proteins. And the Huntington protein will also alter cellular organelles as well. This includes the mitochondrial function, axon transport, and the synapses. Apoptic pathways may be activated and cause neuronal death. So what are the clinical manifestations that you might see? You might see this disease progressing very slowly, and it includes involuntary fragment movements such as chorea. You might see chorea, which is the most common of the abnormal movements, first in the face and arms, and then eventually it's going to affect the rest of the body. Our patients with Huntington's will also have very emotional lability, and progressively dysfunction of their intellectual and thought processes will occur. Eventually, you might see dementia that precedes motor symptoms. Other cognitive deficits will include a loss of memory, reduced capacity to plan, organize, to sequence events, and any one of these features may mark the onset of the disease. You might see restlessness, disinhibition, and irritability as well. Those are very common. Euphoria or depression may also be present. And the evaluation and treatment is based on the diagnosis of Huntington's disease. And you're going to diagnose by family history, clinical presentation, and genetic testing. There's no known treatment that's effective in halting the degeneration or the progression of these symptoms. The disease is unfortunately fatal. This severe degeneration of the basal ganglia is going to cause a depletion of GABA, which is gamma aminobutyric acid. So with Parkinson's, I like to remember that it's not that dope, meaning that there's going to be severe degeneration of the basal ganglia that involves that dopaminergic pathway. You will see clinically Parkinsonian tremors, rigidity, bradykinesia. If you're forgetting what this terminology means, I would go back a few slides to the different movement syndromes. And you're also going to see postural disturbances, both autonomic and neuroendocrine symptoms, and cognitive affective type symptoms as well. The classic motor manifestations of Parkinson's is bradykinesia, tremor at rest, rigidity, and postural abnormalities. Parkinson disease is a commonly occurring degenerative disorder that involves deficits of dopamine. This is why I put it's not that dope. It doesn't affect the gamma aminobutyric acid like Huntington's. It's not going to affect norepinephrine or acetylcholine. Only dopamine. It's a complex motor disorder that's accompanied by systemic, non-motor, and neurologic symptoms. And the onset of primary Parkinson's begins after the age of 40 years old, with the incidence increasing after the age of 60. We also will see alterations in movement that affect the upper motor neuron, and these are called upper motor neuron syndromes. So hemiparesis, hemiplegia, these are associated with the pyramidal motor syndrome, and you're going to have paralysis or paresis of the upper and lower extremities on one side of the patient. Where dysplasia is a paralysis of the corresponding parts of both sides of the body, and this can result from cerebral hemisphere injuries. Paraparesis or paraplegia is the weakness or paralysis of the lower extremities as a result of lower spinal cord type injuries. So when you think of hemi or hemiparesis or hemiplegia, this is upper and lower extremities, but only on the one side. But para is talking just about the lower extremities. Quadriparesis or quadriplegia is the result of all four extremities, upper and lower, and it usually is a result of an upper spinal cord type injury. Pyramidal motor syndromes are motor dysfunctions that result from the interruption of the pyramidal system, and you will only see temporary paralysis. And lastly, spinal shock, which is also a temporary condition. You'll have a temporary loss of all spinal cord function below the lesion, but again, you're in shock and it's temporary. You can see with this schematic also the difference between the upper motor neuron versus the lower motor neuron and the different types of etiology as well. You'll see it again on the next slide as we talk about the lower motor neuron syndromes. The lower motor neuron syndromes, these are the large motor neurons in the anterior horn of the spinal cord and the motor nuclei of the brainstem. And you will see the axons from these nerve cells bringing these impulses from upper motor neurons to the skeletal muscles through the anterior spinal roots or the cranial nerves. Lower motor neuron syndromes will impair the voluntary and involuntary type movements, and the degree of paralysis or paresis is proportional to the number of lower motor neurons that are being affected. So if only some of the motor units that supply the muscle are affected, then you only have partial paralysis or paresis. But if all the units are affected, then you're going to have complete paralysis that will result. The clinical manifestations that you might also see are proportional to the degree of the dysfunction itself. But the precise manifestation will depend on the location of the dysfunction in the motor unit and within the CNS. We will see flaccid paresis or flaccid paralysis with lower motor neuron syndromes, as well as hyporeflexia or areflexia. You can use this table to help differentiate between the previous slide showing upper motor neurons with the lower motor neuron type differences. Lower motor neuron syndromes can be seen with the following diseases here. Guillain-Barré syndrome is a very common one where we'll see lower motor neuron syndrome. And with Guillain-Barré, This is an autoimmune disorder that's characterized by your own immune system attacking the peripheral nervous system. And it can occur after infection, like a respiratory infection or GI type infection, and then your body is put in this overdrive of immune response that can result in Guillain-Barré syndrome. And it affects the myelin sheath of the peripheral nerves that lead to weakness, numbness, and in severe cases, even paralysis. Guillain-Barré syndrome, your patient can be resolved of these symptoms. With bulbar palsy, this is a condition characterized by an impairment of dysfunction of the cranial nerve that controls the muscle of your face, your tongue, and your throat. And it can be a result from various causes like a neurologic disorder, a lesion of the brainstem, or genetic conditions. With this type of bulbar palsy, it can lead to difficulty with speech, swallowing, facial movements, and it really depends on what specific muscles are being affected by the palsy. ALS, or amyotrophic lateral sclerosis, is also called Lou Gehrig's disease. It's a worldwide degenerative disorder, and you lose both lower and upper motor neurons with progressive muscle weakness. Amyotrophic, meaning without muscle nutrition or progressive muscle wasting, refers to the predominant lower motor neuron component of the syndrome. Lateral sclerosis is the scarring of the corticospinal tract in the lateral column of the spinal cord, and this refers to the upper motor neuron component of the syndrome. It's important to understand what comprises the A, the L, and the S. Now, ALS can usually begin at any time from the fourth decade of life, so in your 40s, and its peak is around 60 to 69 years old. Occurs about 3.9 cases per every 100,000 persons in the United States, and it's higher in males than in females. Most cases of ALS are sporadic, and they have a familial form with genetic mutations on chromosome 9. We will see gene and environmental interactions that are now being evaluated as the cause of ALS, and there is now genetic testing that is available. In terms of the pathophysiology, the cause of ALS is largely unknown. We know that there's apoptotic factors, abnormal synthesis of filament units, and defects in the axonal transport. We'll have glutamate, excitotoxicity, oxidative stress, growth factors, mitochondrial dysfunction, and even neuroinflammation as well. But the principal pathologic feature is that ALS is degeneration and death of the upper and lower motor neurons, and it includes the neuromuscular junction as well. So you're going to see a decrease in large motor neurons in the spinal cord, brainstem, and cerebral cortex, with ongoing degeneration in the remaining motor neurons. The nuclei of cranial nerves 3, 4, and 6 are not going to be involved, so therefore you will have extraocular motor movement intact. However, there's also widespread neurodegeneration of the non-motor neurons in the spinal cord and the motor cortexes, and as well as the premotor, sensory, and temporal cortices as well. The lower motor neuron degeneration will denervate the motor units, and so adjacently you'll have viable lower motor neurons that attempt to compensate for some time. What are you going to see clinically in your patient? You may see focal muscle weakness beginning in the arms and the legs, and then it will progress to muscle atrophy. 60% of individuals have a spinal form of the disease, and this is what you would see. Also with a spasticity and loss of the manual dexterity as well as gait. The initial onset, though, can be very subtle. Patient may complain of cramping of the arms and legs, weakness that affects the limbs, incoordination, slurring of speech, and difficulty swallowing. Muscle weakness in ALS exhibits the following type characteristics. You may have paresis that begins in a single muscle group, and then corresponding muscle groups are asymmetrically going to be affected. You'll have gradual involvement that incurs all the striated muscles except the extraocular muscle and the heart muscle. Flaccid and spastic paresis can coexist. Urethral and anal sphincter weakness is very uncommon though. The diagnosis of ALS is based predominantly on your history and physical of your patient, and once they've ruled out, there's no evidence of other neuromuscular disorders. Electromyography that tests the muscle reaction, as well as muscle biopsy, can help to verify lower motor neuron degeneration and denervation as well. You can also get imaging studies and test your cerebral spinal fluid biomarkers to help make the diagnosis. Now, ALS is fatal, and usually it's from respiratory failure within 3 years of the diagnosis. The ventilatory issues become prominent because at some point you will have salivation problems with thick saliva, excessively thin saliva even, and dyspnea that's caused by diaphragmatic and intercostal weakness. A small percentage of ALS patients will live 5 to 10 years or longer after the onset of symptoms. We also have disorders of posture or stance. Dystonia is the maintenance of an abnormal posture through muscular contractions. And with this, you'll have equilibrium and balance that's being disrupted. With muscular contractions that are sustained for several seconds, we call this dystonic movements, when contractions last for longer periods of time. And it's also associated with basal ganglia abnormalities. You will see an inequality of tone due to the loss of normal postural reflexes, resulting in posturing of limbs. So you might have remembered from health assessment decorticate posturing. So when you court someone or date someone, you hug them. So I remember that to help me know that this is when the arms are moved in a very flexed way, but the feet are moved out. With deliberate posturing, you have a movement out and that extension of the arms and hands, and the feet are still moving in the same way it did with decorticate posturing. We also have neck dystonias like torticollis, laterocollis, retrocollis, and anticollis as well, depending on the direction. More commonly, we see torticollis. Basal ganglion posture. Remember, we've seen this type of cogwheel type rigidity where you have shuffling and trembling of the extremities, rigidity of movement, and you'll have this forward tilt of the trunk. We also know about senile posturing, which we'll see kyphosis, where the upper curvature of our back or spine is exaggerated. Let's look now at disorders of expression, and they involve the motor aspects of communication. Hypermimesis, hypomimesis, and dyspraxias and apraxias. Now, hypermimesis is the disinhibition that's commonly going to be manifested by pathologic laughter or crying, and it's associated with the right hemisphere type injury. The pathologic crying is associated with left hemispheric injury. Okay, so laughter, right, crying, left. But the exact pathophysiology of why this happens is unknown. Hypomimesis, this is going to manifest as a prosody. And a prosody is the loss of voice modulation. So they can't really change pitch, speed, emphasis, or motion. Receptive aprosity involves the inability to understand emotion in someone's speech and facial expression, where expressive aprosity involves the inability to express emotion when they are speaking, and they do not have facial expressions. When you have a patient that is dealing with aprosity, this is associated with the right hemisphere type damage. Dyspraxia is the partial inhibition, and apraxia is complete inhibition or inability to perform a purposeful or skilled motor activity in the absence of paralysis. In the absence of sensory loss, abnormal posture and tone, abnormal voluntary movement, incoordination, or inattentiveness. These are disorders of learned skill movements, like arm and hand movement when you're eating, standing and turning around, blowing out a candle. Dyspraxia and apraxia are associated with left hemisphere vascular disorders, particularly if a patient has a stroke that affects the left hemisphere, or if there's a brain tumor, infection, metabolic disorder, or any type of degenerative disorder affecting that left hemisphere. And both the motor and sensory neural pathways can play a role in this skilled movement. Okay, so that's dyspraxia or apraxia. And lastly, but also very important, is this term extrapyramidal motor syndromes. Because the extrapyramidal system encompasses all the motor pathways except the pyramidal system, there are two types of motor dysfunctions within the extrapyramidal motor syndromes. We have the basal ganglia motor syndromes and the cerebral motor syndromes. But unlike the pyramidal motor syndromes, both the extrapyramidal syndromes result in movement or posture disturbances without significant paralysis. With basal ganglia motor syndromes, these are movement disorders that involve either a paucity or an excess of movements. Stress, nervousness, tension will all typically worsen these symptoms. When your patient is relaxed, it will improve their motor performance. You'll see involuntary movements such as tremor, chorea. You'll see dystonia as well. And they can be associated with brain trauma, strokes, tumors, infection, metabolic disorders, multiple sclerosis, and even Parkinson's disease. It can also be a side effect from medication. They're characterized by alterations in muscle tone and posture. Rigidity, together with cogwheel phenomenon, is present in all muscle groups, but it's most prominent in those that maintain flexed position. With cerebellar motor syndromes, this is going to involve the cerebellum, and it can result in acute loss of muscle tone, difficulty with coordination of voluntary movements, or ataxia, and minor degrees of muscle weakness. Tendency for this is toward fatigue, and it can also be with the impairment of associated movements. Lastly, the disorder of equilibrium, posture, and gait can also be present with cerebellar motor syndromes. Hence the terminology cerebellar, which talks about the cerebellum, which gives us this sense of equilibrium, posture, and gait. They're associated with hereditary ataxias, strokes, brain trauma, multiple sclerosis, tumors, and even systemic disorders like exposures to toxin, heat stroke, but they also can be idiopathic as well. The cerebellar effects can be ipsilateral, meaning that it affects the same side of the body. So the damage to the right cerebellar generally is going to cause damage and symptoms to the right side of the body. So wherever it is in the brain, it's also going to be on that side of the body. Now, there's one key distinction between the pyramidal and extrapyramidal system, and this is the nature of the connections in the pathways that are involved. The pyramidal system primarily consists of direct connections between the motor cortex and the spinal cord, and this is going to allow for very precise voluntary movements. However, the extrapyramidal system involves more complex and indirect connections, and this will incorporate multiple structures and circuits that contribute to the regulation of posture, coordination, and the involuntary type movements. Last question for practice. Which of the following is a characteristic feature of extrapyramidal motor syndromes? Take a minute to look back in your notes and previous slides, and you may need to take a pause. The answer here is intention tremors, B. The extrapyramidal motor syndromes encompass a group of movement disorders that result from the dysfunction or the damage to the basal ganglia or the connections. And these will involve abnormalities in movement, control, posture, and muscle tone. So intention tremors, these are characterized by very rhythmic oscillations of body parts during purposeful movements. And it's a very common feature of the extrapyramidal motor syndrome.